This podcast is also part of a pod course, which is available for credit on speechtherapypd.com. All you need to do is register for the course, complete the requirements, and you will receive credit. Speechtherapypd.com is a video continuing education company, a certified ASHA CE provider.
Hi, folks, and welcome to First Bite, Fed, Fun, and Functional. I'm your host on this nerd venture, Michelle Dawson, MSCCC SLP, the All Things Peds SLP. This podcast was, like most creative processes, birthed from a combination of several cups of coffees and, honestly, even more questions posed by a series of impassioned graduate students that I've had the pleasure of supervising over the last several years. First Bite's mission? It's to answer those questions that we've all had, but we've either been too afraid to ask or we didn't have the subject matter expert saved to our own personal speed dials. So, do you too have more questions and answers when it comes to treating your medically complex and fragile pediatric patients? Are you unsure if the signs and symptoms that you're observing are indicative of an allergy, maybe an underlying GI issues, or could they possibly be neurologically driven? How many questions do you really have for that registered dietitian regarding the formulas prescribed and the flow rate through that patient's G-tube? Have you ever been consulted for a quote-unquote difficult latch only to find out that the mother's exclusively breastfeeding, but you've never nursed a little one or worked with the breastfed patient before? And what about functional communication? Are you so over flashcards, but you need advice on how to get started with core vocabulary with a non-speech generating device, or how to find the right fit for a speech generating device? Do you have additional worries about the basic day-to-day running and documentation of your private practice? How do you go about obtaining referrals or even documenting that note so that the insurance company deems it medically necessary? If you answered yes, well, then come join me, Michelle Dawson, for this dynamic podcast presented by speechtherapypd.com. Who am I, you ask? Well, I'm a self-described SLP geek with, as my family says, a touch of the ADD and ADHD. I have a passion for serving the least of these, namely the most complex and involved pediatric patients in their natural environment through my private practice, Heartwood Speech Therapy, in the Columbia, South Carolina metro area. I also have had the pleasure, and currently still am, traveling the country where I lecture on best practices for pediatric dysphagia and functional language acquisition delivered through an early intervention natural environment model. Are you still intrigued? Then come join me as I interview some amazing folks. And don't forget that you can submit questions for a Q&A or interview request topics to me via email at firstbite@speechtherapypd.com or on our Facebook page. And also check out our website. Drop a review. Subscribe to obtain those coveted ASHA CEUs. All right, folks, let's get right to it. Welcome back to First Bite, Fed, Fun, and Functional Resources for the Pediatric Clinician. I'm your host, Michelle Dawson, the All Things Peds SLP. The topic of today falls in the Fed category, and I am once again joined by the amazing Miss Erin Forward, our upstate South Carolina gal by way of Rochester, New York, who, if memory serves correct, is only a few weeks away from her official graduation. Can we get a whoop, whoop? You're almost done, baby. And as I mentioned in episode 4, this pod course is possible because of a seed that she planted with me a year ago. And as such, I sweet talked her into this adventure, of which she graciously obliged. And tonight, Erin and I will be covering treatment of pediatric and feeding and swallowing disorders, but specifically our populations that have feeding tubes. I'm thinking like long-term feeding tubes at that. So on that note, Erin, please catch folks up to speed about who you are and where you studied before we dive right in.
All right, so for those of you that don't know, I grew up in the cold Rochester, New York. I went to undergrad at the University of Pittsburgh, where I have a degree in psychology and communication sciences and disorders. I then moved further south to the University of South Carolina, where I am almost finished with my master in speech pathology and am finishing up my final externship in Greenville at the Children's Hospital inpatient.
So what is it, like August 9th? Is that we got like...
Yes, the 10th.
The 10th. So we are like two and a half weeks away. So yay!
We're getting there.
You're going to survive. It'll be fun. All right. So we are going to tackle feeding tubes tonight. And again, it's roles reversed, which always puts me in the hot seat and makes me, pick Michelle in tonight. So I will hand the imaginary mic over to you for the cues, and I'll do the A's.
All right. Well, I think especially as a new clinician, a big question that we have going into working with a child is, how do you begin treatment with a patient that has a G tube or versus a J tube?
Okay. All right. So my first thought is, how many student clinicians or new to the field of pediatric dysphagia clinicians know the difference between a G and a J? So a G tube goes directly into the stomach. The J tube goes into the second portion of the small intestines. The old rule of thumb is, the lower the feeding tube, the more complex and sick the kid is overall. So I know you folks can't see me, but I've got my finger on the bridge of my nose. If it goes through their nose, we anticipate a feeding tube 4 to 6 weeks tops. I've heard tall tales out in California where they'll put a nasally placed feeding tube in for 12 months, but that is the exception rather than the norm. A child that gets a G tube has it in 6 weeks plus, but we're planning ideally to get off of a feeding tube, or in worst case scenario, maintaining the feeding tube. But their overall health of their intestines are pretty good. If you have a kid that has a J tube, they're pretty much on continuous feeds. J tubes last, when you get a J tube fed baby, it's 18 to 20 to 22 hours a day that child is connected to a constant slow drip feed, typically of like an elemental formula like Alimentum, or something that's broken it down to just the minutest levels. I think I interviewed Mr. Jeremy Pons, who's an amazing registered dietitian, and has talked us a really good job explaining about the different types of formulas. But then there's this weird combo one that's a GJ. Have you seen a GJ yet?
Yes.
Okay, cool. I actually didn't see a GJ tube until like 4 or 5 years ago. It was like the mystery tube that I didn't know what I was getting into. And then I saw it in real life and I was like, that looks totally different than it did in the textbook. But y'all, a GJ tube, it's one hole through the stomach, but it has 2 kind of like valves or 2 kind of ports. The gastric one goes directly into the stomach. That's where we could do our bolus feeds during the day. And the J portion runs through, has a tiny tube that runs internally through to the second portion of the small intestine. And that, has it allows for the continuous overnight feed so that we can just pack in the calories. So there's our crash course in tubes. But my first thought when I get a kid that has a feeding tube, I need to understand their flow rate. I need to understand their timing, because I need to time my therapy sessions when their stomach or their gut is the most empty. So if you think about it from our G-tube kids, if their last bolus feed was at like 10 o'clock at night, spread out over an hour, and their next feed's at 9 o'clock in the morning, I want to get in the door around 8:30, 8:45, or worst case scenario, right at 9 o'clock when they're first getting connected, because they recognize, or hopefully that's your best chance for the child recognizing their hunger cue. That a lot of times you'll see these are the kids that if they've had like a feeding tube long term, they're playing with their buttons, they're spinning it. Sometimes they'll gesture towards a feeding tube can. I've had kids that made a subtle little sound like this. They're like pressing their tongue up against the surface of their palate and kind of creating like a sucking motion. Sorry if I popped everybody's eardrum with my imitation of that sound, but there it is. But the catch is, if you have a kid that has a J-tube feed, you don't want that first one in the morning. If they've had a continuous overnight feed through a J-tube, or sometimes a continuous, and it happens not as often, but a continuous slow feed through their G-tube overnight, you want to hit them when they've actually had their pump turned off for a little bit. That way they can feel hungry, even if it's just their gut being slightly less filled. But that's first and foremost. I need that baby to recognize a hunger cue and know that they're hungry. Does that answer? That's a long-winded Michelle Ann question.
That does answer that question.
Okay.
How, with a child that has a J-tube, if they, they're having those continuous feeds, do you look at them differently, seeing as they don't have that food sitting directly on their stomach, as far as like similar to a child that has a G-tube?
Yes. Before I feed a kid that has a G-tube, I want in writing from the pediatrician or the GI, whoever's running point, as to what they can actually safely consume. I've worked with a couple of kids that had J-tubes. One of them succumbed to the underlying etiology. And the doctors were very, very specific about what they could and could not eat because the gut was so compromised. One kid was allowed green beans and only green beans. And his overall long-term plan was he's never getting off of the feeding tube. I mean, he had short gut syndrome. We had CP. We were 25 weeker. We were status post, like, I can't remember how many bleeds. I think it was like 2 or 3 small grade 2 bleeds. His medically fragile foster, she called herself grandma because she was in her early 70s. She just wanted him to increase the quantity of canned green beans that he can masticate through in a 30-minute meal with the family. And that baby, his goal was to go from 1 green bean in 30 minutes to 4. And he would pick up, and they were like, honest to goodness, some of the slowest sessions that I've ever done for therapy, because I'm sitting there eating my 4 green beans with his, but he'd pick it up and go, finger licking good. And he would eat it. He also knew all the old Southern hymns. And so in between eating of green beans, he'd bust out a hymn. So sweet child. But his plan of care was significantly different than the kid that I have that has a G-tube, because his quality of life is different. Like, we know we're not getting that kid long-term off of the J-tube. He's going to always need it for nourishment, but it's quality of life that we're focusing on.
Mm-hmm. So speaking of that, talk to me about quality versus quantity versus feeding tube dependency.
Okay, so our NICU folks are probably privy to quality versus quantity way more than our home health clinicians. That being said, we gotta
encourage that in this setting too. Also, side note, squirrel, if you're working in the NICU, get your hands on anything and everything you can by Catherine Shaker. She's amazing and brilliant, and I have super nerdy girl crush on her. That would be your go-to source for that. I want to print off some of her like Q&As and get her to sign them just because I think she's amazing. But
agreed.
Yeah, agreed. We're all like, oh, grow up and be Catherine Shaker. Yeah. Quality feeds means we're not as stressed out about the volume that is taken orally. Scratch that. Yeah, there it is. It's been a long day, folks. We're all here. With the quality feeds, I'm not that stressed about the volume by mouth. I want a good feed. I want that child who has had a lot of negative oral experiences to have a pleasant experience. And maybe it's the first pleasant experience that kid's had. I mean, I've had the kids that were in PO coming home from the hospital, and 6 months later after being home, they finally, through thin liquid or, water trials, they are allowed PO for the first time after an instrumental exam. But that entire time they were getting their tube feeds. So I want them to have positive oral experiences. Are they in fight or flight, or are they comfortable? Are they neutral? And I know you've seen that in homes with me. I know you've seen that at the hospital that you've worked at, but feeding therapy has to be positive to neutral. Worst case scenario. The second you go from neutral to fearful or stressful, the child is set for failure. And that's where quantity feeds kind of interplay in. Quantity feeds fall in that neutral to negative fearful zone. And unfortunately, nurses get a bad rep for quantity feeds. All nurses are not that way, but that's what a lot of our professions run up against. And I've run up against that in the home health, where the home health RN is pushing, getting, 3 or 4 ounces by a bottle in the child's mouth, and the child has overt signs and symptoms of aspiration. We've got nasal regurgitation and it's dripping out. We've got a significant change in vocal quality and a wet cough. But they're so adamant that the child will reach the quantity by mouth, but they're not looking holistically at the child. And I've also seen well-meaning parents that just so desperately want their child to take food in by mouth that they're just looking at the quantity and not the quality of the feed. Some of our more rare diagnoses that I've run up against, I've had some old school pediatricians that, it's the Deep South. We have some unique opinions on female intelligence at times. You like how I'm skirting this? Folks, you can't tell it, but I'm blushing. But sexism is a real thing. We'll acknowledge that. But sometimes with these rare genetic conditions, we need feeding tubes because the metabolic rates, absorption rates for these kids or their underlying cardiac conditions, I need the quantity feed through their feeding tube so that we can work on a good quality feed by mouth. Mm-hmm. So, does that one? All right. And then you asked about another term. Feeding tube dependency.
Mm-hmm.
This is the bane of our existence. Man, if we had a quick fix for this, none of us would have a job, right? All right. So feeding tube dependency is where the child has pretty much been feeding tube fed from the get-go. and they have zero desire for food by mouth because it has no merit to them. Their brain, mouth, their gut is not connected, and they don't understand why we even show up once or twice a week and try to convince them to shove something in their gullet. That's unfortunately, very common with our incredibly complex kids. Mm-hmm. I'd say I've seen it as young as I have a kiddo right now that she is adjusted age 10 months and we're battling it. And she was all PO up until about 5 months and has lost it that quickly. Or has transitioned to feeding tube dependency. But I mean, your practicum site right now, you have to see it on the get-go, like the build up to feeding tube.
And that's the thing that's interesting is seeing kids in home health who have the G-tube. You're working on, PO trials, all that kind of stuff, but then being in the hospital and seeing the process of them getting to the point where they need a G-tube, where you have a child come in who, they can't figure out what's going on, why their failure to thrive, why it's slow weight gain. And in some instances, a child that at 6 months has already had so many negative experiences with PO because of reflux or allergies or anything. And then I've seen
clefts.
Yeah, them making the decision to get a G-tube, which is hard in and of itself, but being on that side of the before and seeing the after, but realizing that that's what they need to do to heal.
Yeah, I had a kid with EOE. He was a Thursday afternoon kiddo. I don't know did you see him with me last summer?
The little one?
He had EOE, sweet little booger.
With his hair?
Yes.
Yes, I remember him.
Y'all can't see it. We're like gesturing to each other. That little guy, he was exclusively breastfed. And then at 9 months, his weight started tanking. And unfortunately, it's not like our breasts are attached to a spigot to say you're producing this much volume at this time, right? Trust me, every mother in America would love that. I would have. But at 9 months, his weight started tanking, and he had eczema from the get-go, but allergies ran in the family, so they just, they didn't think of anything of it. But when he was 12 months, his doctor hospitalized him with a failure to thrive diagnosis, and the report that I got was it was mother failed at baby-led weaning, mother failed at properly introducing PEO trials. This is a behavioral feeding aversion. And a nurse practitioner that was a dear family friend advocated, and they finally scoped him, and it was the worst case of EOE that any of them had seen. His esophagus was just decimated. And he went from being like 90 something percentile down to like 3rd or 4th percentile before they finally got the feeding tube. And strict NPO for 8 weeks. And then when I got him in that 8-week time period, he had gone from exclusively only breastfeeding and wanting nothing by mouth, like no food by mouth, to he didn't know how to take a bottle. He didn't know how to take an open mouth cup. He didn't know how to take a transition hard-nosed sippy cup because he had only gone from boob to NPO. And we had an uphill battle, and that was just in 8 weeks. 8 weeks, drastic feeding tube dependency. By grace, we powered through that one, but that took a minute. So, and he has so much more hair now. Oh my gosh, so much more hair. Like, funny thing, when you're fed, you grow hair and teeth, as well as cankles. That's a thing.
Oh my gosh. Well, with those in instances like that, with those children, or a child that very early on received a G-tube, how, speaking of functional, how do you evaluate those skills? Like, I remember you talking about, these children a lot of times aren't going to look like a typically developing child when they eat food, but if it's functional and it's safe, then that's what they need.
Yeah. I try to, on my eval, try to figure out what I call their food age. So they may be, all right, so hypothetical case, they're 12 months chronologically, and they were 2 months premature, so like adjusted age 10 months. Let's say they had like a grade 2 brain bleed, so they're developmentally like 10 months. So most families understand the terms chronological, adjusted, and developmental because they've had numerous appointments and specialists in the whole 9 yards. So then I talk about, okay, but let's look at how well they've integrated their reflexes for eating, whether it be has their phasic bite reflex integrated into a vertical chew pattern? Have they integrated their tongue protrusion reflex, or are they presenting with tongue thrusting because it's been such an extended period of time? First and foremost, I had to go back and learn all those terms because I didn't get them in school. You got lucky, lady. I'm old. You see all this gray hair? You had a pediatric dysphagia class. I got one night in grad school, a million years ago. And, I graduate and they say, you too can treat all of the tiny humans. And you're like, I know exactly what I'm doing. And then I got out and I was like, I don't have a freaking clue what I'm doing. So I had to hit the books and research hard to be able to identify and describe what they were currently looking like. I mean, if that kid looks like and acts like developmentally a 9-month-old, then toss their chronological age out the window and start with what you would feed a typically developing 9-month-old. Meet them at the food age that they're presenting at, and then make it functional. I don't use chewy tubes because food's not plastic. I don't use Z-vibes because food doesn't vibrate. And those are not my words. I had the pleasure of reading and meeting the ladies who wrote Food Chaining. And yes, they signed my copy. And yes, I have that copy because they're goddesses. But, they flat out said food doesn't vibrate. And I hear numerous tomatoes being thrown at me through the internet. Second. Oh, she said that. But if I want them to work on a chew, then I'm going to give them food to chew on because I desperately need these kids not to learn mastication and isolation. The central pattern generator for mastication does not talk to the central pattern generator for respiration. Mastication talks to the central pattern generation, CPG for swallowing, and the CPG for swallowing talks to respiration. So if I teach mastication and isolation only by chewing on something hard and inanimate, when I actually stick food in, they're more likely going to have premature spillage and aspirate on that because they don't know how to integrate that bolus that breaks off and control it to swallow it safely so that the respiration component, the aero portion of the aerodysphagia or aerodigestive tract is safe. I'm going to do safe PO trials. If I know that a child is not going to be able to masticate through hard celery or a hard carrot, then I'll give them that. If I know that they can bite through things, I'll try one of those silicone net feeders. I don't like the actual cloth net feeders. Man, I used to recommend everybody get those cloth net feeders. And then I became a mom and shoved a banana in there one time. And I was like, how do you clean this? So you've seen my culinary skills. What?
No, they're not bad.
So I just throw the nut ones away and give up. But the silicone net feeders, I can control the amount of the bolus that comes through by controlling the amount of food that I put in. And then when they bite down, they get the positive feedback of there's a food and that they have to swallow this bolus, and the swallowing CPG talks to the respiration CPG. So those are all factors that go into my long-term planning. I need to know where are they currently functioning, find and determine their food age, and then say, okay, well, let's functionally move forward on something that's pleasurable. And again, I cannot stress enough, feeding therapy has to be positive to neutral at best. The second we go south, as the folks in New York City would say that I just met last week, forget about it. Did I do that all right? Did I totally? You do it.
Talk like that. I can't. I'm not New York City.
Yeah, but you're Italian.
Forget about it. For your long-term plan, aside from making it functional, making it pleasurable, I know that a lot of times parents' first question is, okay, well, when are we going to get off of the G-tube? Mm-hmm. How do you develop that long-term plan with them, with their long-term goal, a lot of times being that?
Get rid of the tube.
Mm-hmm.
Yeah, that's a tough one. First and foremost, my question is, are you prepared emotionally to have those crucial conversations? And are you prepared emotionally to be a good listener? Because most of these parents are speaking from a position and a placement of fear. Bear had his helmet. Bear was, my Bear was special looking there. And all I wanted was for Bear to look normal. Oh my God, I just wanted him out of that helmet. It wasn't a feeding tube, but it was super, super obvious, right?
Okay.
So a lot of these families just want their children to be able to break bread with them at the dinner table and for a holiday. Mm-hmm. So one, be prepared for an emotionally charged topic, but also ethically, we're required to create and set realistic goals. So before I open my mouth, I need to understand, where is GI and PEDS coming from? Do they have a goal for, are we just doing this for weight gain? Is this temporary until the underlying cardiac condition can be repaired, especially for our kiddos that have Down syndrome? Mm-hmm. A lot of them have PDAs, holes in the hearts, and they might need a feeding tube just until they have the holes repaired. But sometimes, yes, they do have it. I had one kiddo that was exclusively breastfed, had open heart surgery at 6 months, coded twice on the table. When they came to, he was self-imposed NPO. He, no matter what they did, he was such a sweet boy. And I got him at 4.5, and he could only take thin liquids. He had no idea how to manipulate a bolus because he had just refused because of the feeding tube dependency for so long. So his goal was, yes, let's rapid fire get him off this tube. But even though he was 4.5, he ate like 4 or 5 month old, only knowing how to handle thin liquids. So we had to start all the way back with the food age of a 4 or 5 month old. Whereas, and we made progress. Don't get me wrong. We made really, really good progress, but and cases like that are tough because he'd had a lot of clinicians before me. Mm-hmm. So then you walk in the door and you're like, oh, what am I going to do different? Which was incredibly nerve-wracking because he'd had some really good clinicians before me. But I think for that particular child at that point in time, the family was ready to sit back and not force a quantity feed by mouth, and to hang in there for the quality. And that was the biggie, was they had finally come to terms with the fact that this tube is in long term until he develops the skill set in order to safely feed. Mm-hmm. But I I cannot be the only one who has reservations about using plastic and things that vibrate in functional therapy. And I'm not talking for the kid that has, I mean, we all know the child that has severe and profound autism spectrum disorders or intellectual disabilities. And if they don't have something to chew on, they will bite everybody and everything. I'm not talking those kids. I'm talking the kids where we're working on functional PO. All right. So you've been there, seen it, and had numerous supervisors. Which I feel like after me, like I drilled that so much into you, I feel like I ruined you.
A little, not gonna lie. But well, I think that I mean, I'm not on the Chewy Tube train because I think that it's all about problem solving. It's all about, and like you said, I mean, if you're so worried about a child not being safe to chew, they're probably not ready for it. They're probably not at the level that mastication is something that you like really need to work on right now because other skills that they need prior to that haven't developed. I think sometimes I feel like we look at a child and look at their chronological age and think they need to be eating these certain foods. And we start with things like that. But you wouldn't look at a 3-year-old who has been nonverbal and expect them to start saying sentences, which is, I think, important. And it's hard to look at feeding that way, I think, sometimes.
That's a perfect analogy, and I'm totally going to borrow that. All right. You told me today a case study that you had about the
tongue.
Yes. Okay. That was beautifully stated, by the way.
Thank you. Mm-hmm. Yes, we had a little one who had feeding difficulties. Mom was super frustrated because she couldn't get the bottle in because at open mouth position, the tongue was elevated. And it was brought to our attention that people wanting to do strengthening exercises and things to let the tongue sit more flat and cupped. But you look at this child has cardiac issues and you sit there, and I didn't realize it at first. Like I was helped work through it. You sit there with your mouth closed and put your tongue up and just think about it for a second. It's so much easier to breathe. Mm-hmm. So like we learn, respiration comes before feeding. Like that's the most important thing. This child had cardiac issues, probably working a lot harder to get blood to their heart, which means they have to work harder to breathe. They don't care about eating at that point. But I didn't realize that at first. That's not something you're learning necessarily in grad school, but it's so interesting how kids they already developed these strategies for what's the most important to them, and they're communicating that with us. That child doesn't care about eating because it's too hard for them to breathe. That's them communicating that with us.
Yep. It's respiration first. It's always respiration, then deglutition. And when I have a kid that's posturing on bottle, I mean, yes, I know the first thing that we should be thinking of is GERD because GERD can be the underlying cause. But when I see them arching and turning away and then going back to, a lot of those kids, if you listen to them, they also have a stridor. And, there's your baseline laryngomalacia, trachomalacia. You got to start worrying about that. And I mean, I go into rural areas and sometimes I wonder, are we actually catching all the cardiac kids before they get discharged from the hospital? Like, I mean, I had a kid that was discharged from the hospital, recurrent hospital stays, and finally at 6 months old, they diagnosed the kid with like pretty significant Hirschsprung's disease. I mean, the back parts of this little guy's intestines were just not innervated to move stool through. I mean, he did not want to eat, and they were forcing quantity in this kid's mouth when he was just, relaying at a 6-month-old level by turning away and crying and posturing during feeds and straining with bowels that he lacked the innervation to excrete his, poop. Mm-hmm. We work with babies. We can say poop.
Or as Bear would say, poopsies. But.
Poopsies, yes. As my bear would say, poopsies. Y'all, I have a very opinionated 3-year-old. This is his father's fault. So, oh my goodness. All right, which feeding tube kid has stuck out with you? Which feeding tube kid is, and their long-term plan? Have you had one yet that's pulled at your heart?
I mean, I feel like your kids I always go back to because
you had them for so long.
I remember the one that always stuck out to me was our little friend that had, what was it? A grade 3 lopsided, grade 4. And that was my first experience with, perinatal pediatric stroke. And that was so interesting to me. And she's I was amazed by all the things that she was doing, but it was really cool to see her progress.
Yeah. I've had that little girl for 2.5 years. In October, it'll be 3 because I've had her since she was discharged from the hospital. I mean, feeding therapy is not for the faint of heart. We are finally, she had it was a grade 4 posterior right CVA that led down into her brainstem, a grade 3 anterior left and a grade 2 posterior left temporal occipital lobe. I mean, she's a miracle kid. And she is now drinking thin liquids from an open mouth and or hard-nosed sippy cup. Her mom's a fan of the hard-nosed sippy cup because she likes her carpets to be cleaner-ish. Whatever. I did the same. I'm not going to judge. I educated her to the change in craniofacial structure with a cup. And she said, whatever, Michelle, I don't care. I don't want my carpets messy. And I was like, truth be told by the mother. But she's eating everything. And she's a salt baby. Oh my gosh. Anything that's salty or umami, she can get her hands on. She's down with it. But
she was my, looking at functional. She was the one that I was like, this is what functional looks like. And it's not going to always be pretty, but she's her neuroplasticity was pretty amazing.
Yeah. And her long-term plan is as soon as we can increase the total volume of liquid safely by mouth, then she'll get her tube out because she's meeting caloric intake. With everything else, it's just the water. And I don't think she's had a formula feed through her G tube in, Johnny on the spot. 2 or 3 months. But that's just it. I mean, that was a 2.5 year, almost 3 year game plan. And we're close. And I can't ethically say your child will have the feeding tube out by December, but I mean, I can hope before her birthday in a year that realistically, if she keeps going at the rate that she's going, I could realistically see that, happening. I just cannot ethically say that. Yeah. We all get mushy over the babies. The kids that pull at your heartstrings and that you fall in love with. All right. Well, we've got 3 minutes before we have to switch to questions. So anything that you wish that you had known when you were first starting with peds dysphagia and feeding tubes?
I feel like I feel like you just realizing they're not as scary. And not scary, but as intimidating.
No, it's scary.
We forget that and I think doing a lot of research, I think it made me, what was the thing I said to you about I think it was like the second week we were talking about, I don't know, because this was before my pediatric dysphagia class. So you just gave me like a crash course in all things. And I had my little notebook. But you realize the more you learn about pediatric dysphagia, the more you realize you have to learn. Like kind of like the more you learn about makeup, the more makeup you realize you have to buy to look like you're not wearing makeup. So it's just like the more you learn and the more you realize that like there's so many other things going on that may not be in our scope, but like we have to understand.
So I think what you're telling me is that as of last summer, I no longer wear orange blush. Thank you for educating me away from the orange blush and the lady at the makeup store lied. And that I shared with you that I believe that I'm a functional idiot because I know this much and realize I don't know this much. But yes.
But you know a lot. Like you just know that you need to keep learning. I think that's the thing, realizing you always have to learn.
Yes, this is truth. This is truth. Well, that's one of the reasons. And I know I talk a lot about clinical supervision, but it's important because you ask questions, and every single one of you lovely ladies that I have like sucked into the vortex of pediatric things, they'll ask questions. And my God, when I don't know, I'm like, and then I run home and I have to research it. But that makes me a better clinician and a better therapist to my patients. Yeah. Awesome sauce. Okay. All right. Sorry to get all mushy gushy there at the end, but when you love what you do, that's a fun byproduct and also wise words, whether it pertains to pediatric dysphagia or makeup.
That's a wrap, folks. Once again, thank you for listening to First Bite, fed, fun, and functional. I'm your humble but yet sassy host, Michelle Dawson, the All Things Peds SLP. This podcast is part of a course offered for continuing education through speechtherapypd.com. Please check out the website if you'd like to learn more about CEU opportunities for this episode, as well as the ones that are archived. And as always, remember, feed your mind, feed your soul, be kind, and feed those babies.